Next, we're going to have short reports from the two other networks. The first one will be from the Dental PBRN that's headquartered in Alabama, but there's a component up here at Permanente Dental Associates in Portland. And we have a representative from there, Dr. Dan Pihlstrom. He's the Associate Director for Oral Health Research and Evidence-Based Care in Permanente Dental Associates. He completed his dental degree at the University of Minnesota and then came out here to OHSU for a one-year general practice residency and then had the wisdom to stay. I think it's wise given what's happened in the Midwest this past winter. So even though we've had funny weather here, I don't think it was very funny in the Midwest. He besides practicing in PDA, holds an affiliate faculty appointment in the School of Dentistry at OHSU, where he teaches a course on evidence-based dentistry to first-year dental students. And I think that's an important concept to come from a practicing dentist who's involved in practice-based research to talk about evidence-based practice of dentistry. So he's going to give us an update on some of the activities of the dental PBRN. Dan?
Thank you for inviting me, and my name again is Dan Pihlstrom. I'm a general dentist with Permanente Dental Associates, and I'm going to talk about DBPRN. We don't have a nice acronym like Precedent or Pearl. We're known as that other network. And I've tried to get people to use DIPBURN, but that just didn't stick, so we'll just stick with that other network and go from there. I want to talk about geographically and structurally what our network is, some of the studies that we're involved in, a couple of the results from a few papers that have been recently published, and how you can get some more information about our network. So geographically, we're spread out. We've got 4 distinct regions: Washington, Oregon, which comprises just dentists with PDA, Permanente Dental Associates; Minnesota, the Southeast, Mississippi, Alabama, Georgia, Florida, and Scandinavia. That kind of geographical diversity is both a challenge and an advantage for our network, I think. The specifics of each region are summarized here. Alabama and Mississippi really are, we think of them as a central hub for the whole network. The network chair, Greg Gilbert, who is basically the administrative and scientific leader of the network, is based at the University of Alabama in Birmingham. And there's mostly Alabama-Mississippi region is comprised of small group and solo practitioners. Florida-Georgia region has actually 2 executive committee members. There's a dentist that serves on the executive committee from each of these regions. There's 2 in Florida-Georgia because of such a populated region. Mostly dentists in small group and solo practices. The administrative base is Florida, University of Florida. Each region has its own kind of coordinating center or an administrative base where administrative assistants and scientists go out to practices to train us in how to do protocols. Minnesota, originally it was just health partners dentists, but is quickly spread out into solo and small group practices in Minnesota. Health Partners is a large group practice, very similar to Permanente Dental Associates and Kaiser Permanente. And its administrative base is at Health Partners Research Foundation. Our region, which we just call PDA because we don't want to be confused with Precedent, is just PDA dentists again. Administrative base is at the Kaiser Permanente Center for Health Research. And in Scandinavia, there are about 20 or so dentists, maybe 30 active dentists in Scandinavia from Denmark, Norway, and Sweden, and their administrative base is at the University of Copenhagen. So this kind of diversity has been great because you've got dentists trained on the West Coast, the Midwest, basically the whole East Coast here and Southeast, and then you've got dentists trained in Europe, and their training is a lot different than our training. They have a different concept of how to manage dental caries, how to treat dental caries in many cases. It's fascinating. And as well as you've got different delivery models. In Norway and Sweden, Denmark, you've got nationalized health care, free dental care for people up to 18 years old, and then after that, it's It's not like here. You've got more traditional sort of HMO type practices here. You've got solo and small group practices in other regions. So it's a really great source of diversity, as well as patient populations are very diverse. And it's one of the challenges, and it's one of the things that I think I've learned the most out of in our network is how dentists treat their patients differently. How we all treat dental caries, for example, but we all treat it so differently. It's really fascinating. We'll go into that a little bit. Structurally, this is how it's organized. So we've got this central hub, which is the executive committee that's made up of a dentist from each of these regions. We vote on study designs, which concepts we want to pursue. That then goes to, and that's headed by the network chair, Greg Gilbert, in the University of Alabama. Of course, the NIDCR has overall oversight into it. The protocol review committee reviews studies. That's a function of the NIDCR, and they can provide feedback to our group as to what they like, what they want to change, what they want to see happen with a particular study. And then, of course, we've got IRBs. Internal review boards review there's a different IRB for each region, which makes it very difficult sometimes to do studies because the IRBs gets involved in consent and what the consent have to look like and protocols. But we've managed to figure out ways to make this all work. But it has been challenging. We've only had one meeting like this. It was a few years ago back in Atlanta. Typically, we all meet separately in our regions and have a representative from each of these other regions show up and give us sort of a summary of what's going on in their particular area. These are the studies that we've been participating in, a lot of them. And most of these collection is done. We've got a few of them that are still going. Enrollment is closed. We've got one where we're still recruiting for the study. I want to talk about just two of these. And I guess if there's a theme to all of this, we've kind of focused on, as Don pointed out, I think we've focused on, where we spent the most of our time and resources on has been how do dentists manage and treat dental caries? Very simple, basic question. And when I was on the executive committee, we had all these studies around this topic. I kind of thought, no, it's not that exciting. But actually, once you start looking at the results and how there's so much variability across dentists and how this is done, it does get pretty exciting to see how differently people manage this. I'm also going to highlight another study that we did. This is on osteonecrosis of the jaw. This is a data-only study. It's separate from the Condor study because specifically Kaiser Permanente, which we're affiliated with, and Health Partners have an electronic medical record. And the same patients in the dental offices, we were able to do a data-only study that looked at diagnostic codes of osteonecrosis of the jaw and look at specific factors in those patients that might predict that. So I'm going to go over the results of that. So this was a publication that was in JADA. You can get this online and read it if you're interested. Restorative treatment thresholds for occlusal primary caries among dentists in the other network, the Dental Practice-Based Research Network. And this study looked at, this is a survey that gave dentists 3 pictures of an occlusal surface of a tooth in varying degrees of from enamel decay to probably a root canal looking tooth. And asked them a whole bunch of things that queried them on their ideas around risk assessment, how they manage occlusal decay, what is their threshold for putting a burr on a tooth, and a bunch of other things. And what we found from this is a very interesting study. What we found from this is that the majority of dentists surgically restore occlusal enamel lesions in patients at low risk for developing caries. So in the picture that looked like stain, but and maybe a catch, and it's very difficult to assess. This is subjective. You don't have a film. But these are standardized pictures that have been used, for example, in Scandinavia to train dentists on visual aspects of diagnostics. And if you look at that picture, the majority of dentists will put a burr on the tooth and put a filling on it, even in a patient that's never had a filling before. And we did see variability based on practice type and a number of other factors, but it was fascinating to see the differences in region, because in Scandinavia, they don't do that. They wait, they manage it non-surgically rather, and they wait for evidence of progression, definite progression into dentin before ever putting a burr on a tooth. And even in those cases, they oftentimes do a kind of a hybrid filling or sealant, or many of them don't believe in total removal of decay in a tooth. And that's why they can kind of get around the issue of intervening very early, because oftentimes when there is a deeper cavity, if it's asymptomatic, they won't remove all the decay, they'll fill it at that stage. They're much more comfortable with non-surgical management of tooth decay. It was very interesting. We found that dentists who did not assess caries risk were more likely than dentists who did assess caries risk to surgically intervene in dental lesions. And the implication is that if you have a specific risk assessment in your mind that you use consistently with patients, you tend to be less aggressive or more conservative or more non-surgical versus non-surgical management with fluoride, sealants, things like that, versus surgical management with fillings. The implication in this is this is a survey, and we did do clinical studies that looked at this very same topic, where you had a patient that you were going to place a filling on, and you were asked to look at the radiograph and judge how deep it was before you placed the filling to get an idea of what the threshold for interproximal caries was, and we found very similar results with it. And we all know that this has a big impact on the re-restore cycle that we commonly find our patients in, as well as just the issue of that first filling placed on that tooth and the implications for the risk of that patient over the long term. Many of us come in and see a patient with a lot of occlusal fillings. We think that they're automatically more high risk. But what if the occlusal fillings that were placed were all done in enamel? So we kind of have, this is kind of an important critical point, that decision making when we're going to place that filling. Any questions on that? It's an interesting article. You can get it free online. Look it up. It's interesting. Oh, and practice types. Of course, in our network, this was a challenge, because we've got practice types that are small group solo practices. We've got more traditional HMO type practices, and there's differences. There's differences in how those dentists treat patients in terms of when they surgically place the first filling in it. And and at our national meeting, we found out, everybody was sort of like, well, it's all about the money, you get paid to put fillings in, you maybe don't as much, and so that's what you're doing. But really, after we talked about it in Atlanta, what we found more and more about was that especially among small group and solo practitioners, there was a fear that undertreatment would result in some type of litigation, reporting to the board. The patient goes down the street to see another dentist, and the dentist says, well, it's a good thing you came and saw me, because you've got a bunch of cavities we've got to do fillings on now. And that was something I had never thought about before, being in a large group practice myself. But there was a lot of reasons for why dentists place fillings at this stage in the game, so it was interesting. And we're doing follow-up studies on the clinical aspects. Yes, please.
Does that study also the medication compliance for non-surgical?
Well, this is an important issue with the population and how the populations are different, because in populations that you wouldn't expect to come in, your surgical threshold is lower, because you want to get patients here today, and they may not be back until they have a toothache, so let's do the filling now. So this didn't look at that. No, it didn't. But it was consistent with actual clinical studies that did have patients come in that the practice types had very similar profiles. In other words, the small group practices, and there wasn't huge variation, but there was significant variations where small group practices and solo practices tend to intervene a little bit earlier in the caries progression process than large group practices and public health practices. This is another study, a retrospective cohort study. This was a study that looked at just data only. So Health Partners of Minnesota and Kaiser Permanente have an electronic medical record, common patient identifier in the patient number. And it looked at the incidence of ONJ in the electronic medical record by using basically a query of diagnostic codes. In medicine, they have diagnostic codes for things like aseptic jaw lesion or inflammation of the jaw or bony cyst. So they looked at indications that might represent occurrences of ONJ in about 570,000 patients in these two regions. And we found a total of 23 patients that had ONJ. And we looked specifically at risk factors, including history of bisphosphonate, both oral and IV, history of an immunocompromising disease like diabetes, history of cancer, history of head and neck radiation. And what we found was that the incidence of ONJ was very low in this population that we looked at. There was about 0.6 per 100,000 person years, or 100,000 people. So a little bit lower than what's been reported in the literature, but consistent with some reporting in around 1 per 100,000 people. Many factors contribute to the development of ONJ. My own personal guess is that it's probably been around before, it has been around before bisphosphonates became a commonly prescribed medication. People with steroids and history of cancer treatment tended to get this. The people that did tend to get this were not healthy people, and we did not find a lot of patients that did not have just single risk factors of oral bisphosphonate. In fact, because there were such few patients, it's very difficult to assess how much a contributing factor of just oral bisphosphonates, the Fosamax that people take so commonly for osteoporosis, could impact ONJ development. But we did find some interesting results. This is going to be published in JDR, I think, along with the other Condor study, I think in April. If you want to know more about the Dental Practice-Based Research Network, we've got a website, and it's got all of our studies and information on it. And we try to do, and I know from looking at the studies that Dr. Darun put up, practical science in dentistry on topics that are important to us as general dentists, and that's what our focus has been on. Any questions at all before I turn the mic over? Yes?
Your ONJ study,
Yeah.
you had a very large number of patients. And I was wondering, what were the demographics, and also can you report maybe the prevalence of bisphosphonate use in that population?
I'll have to refer you to the paper for a lot of the specifics, because although I'm a contributing author, I'm not a principal investigator in it. But the patients were all 35 years and older, roughly equal male and female, a little bit higher prevalence of female patients. Unfortunately, the electronic medical record data is not as complete as we liked. For example, inpatient dispensing of bisphosphonates, we weren't able to get inpatient dispenses, only outpatient pharmacy dispensing. And also we had to rely actually on both groups, Health Partners and PDA, had peer review committees or separate committees that sort of tracked ONJ cases. And we actually had to rely on some of those to identify cases that weren't in the medical record. So I would say that the study up here represents another drop in the bucket in terms of evidence around relative ideas of how prevalent the conditions are. And I wouldn't stake a whole lot of, in terms of that pyramid of evidence and evidence-based dentistry, it's definitely not a high level of evidence, but it's, again, something that tells us a little bit more information about the prevalence. Yes? Yeah. Yeah.
What about dentists who use various forms of technology to assess individual lesions?
Like Diagnodent or something like that. It did ask the question, do you use Diagnodent? And not that many dentists were using it that did this survey. So we didn't find a significance in terms of dentists that use DagnaDent were more aggressive or less aggressive. But the whole point of this study is that we know that occlusal lesions are one of the most difficult areas to appropriately and accurately diagnose. And I think that's why many of us tend to be more aggressive, because we've been burned so many times in the past that we got the diagnosis wrong, and we don't want that to happen. So that's why all these technologies are coming out on this specific surface to try to help us figure that out. Yeah. Is there another?
Yeah, just clarification on the ONJ studies. They are available on online, Journal of Dental Research, first online. So they're available to the public. There are actually two studies. There's the Condor study that was conducted by the three networks collaboratively, and then there's this particular study that actually is kind of interesting because it involved text recognition software, and the reason that had to be used is because there weren't codes for ONJ at that time, specific codes. So it was very challenging to do that. If you have a chance, go in and look at those articles. Also, Catherine Posnack, who is a cancer investigator, does a lot of breast cancer research, is also conducting a large study. As you know, women who have breast cancer frequently are provided with bisphosphonates to ameliorate some of the metastases to bone and so forth. And she wrote a commentary on our two studies that you might find kind of interesting as well. So just thought I'd bring that to your attention. Thanks.
Thank you.
Thanks, Dan. One additional point about the ONJ studies that I think these two publications illustrate is the fact that, you know, when we want to study a subject, we have to decide what the best study design is. And so for the ONJ study, the Condor study, we did a case control study. And I think these two studies illustrate why, in some cases, for rare diseases, rare occurrences, you do a case control study. It's not the highest quality of evidence that you get from a study. In fact, doing this sort of retrospective cohort study, which is represented by the big database, and there are issues with the database and how to get diagnoses, but it illustrates the fact that for something rare, if you want to, you look at 500,000 people and you get 26 cases, that's not the most efficient way of trying to study that disease. If you want to get risk factors for it, you go to a study design that may not be as good as far as the quality of the evidence, but you can get enough cases. You do a case control study. That's what we did with the other one. So in the three networks combined, we identified 190 cases that we studied. So it just illustrates different study designs, and if the only thing we were able to do was a retrospective cohort study, like was illustrated in the second, you study 500,000 people and come up with 26 cases, then you can't really draw conclusions. You'd have to go to a population 2 or 3 times that size to get reasonable numbers of cases. So that's why, given the circumstances, you choose different study designs to address different questions. So now we have a representative from the Pearl Network to give a summary of some of their activities. Dr. Jana Ikeda is a private practitioner in Boulder, Colorado. She's a graduate of Creighton School of Dentistry, and she's a practitioner investigator with the Pearl Network who's been involved in several of their clinical studies. So she's going to give us an update on their activities. Jana?
Good morning. My name is Jana Ikeda, and I am a practitioner investigator associated with the Pearl Network. I'm here to give you a brief update of the studies that we're doing presently and to present some of the clinical findings of one of the recently completed studies, which is the endodontic outcome study. The Pearl Network consists of approximately 247 practitioner investigators located in 32 different states. And to drive it home one more time, our goal is to conduct practice-based research in order to collect evidence so general practitioners can go ahead and make better informed decisions for situations that commonly arise in private practice. So Pearl has completed a number of studies, and in the past precedent conferences, they've gone ahead and discussed the findings from the Deep Caries Treatment Survey Study, as well as the postoperative hypersensitivity in Class 1 resin-based composite restorations. Today I'm going to go into detail about the endodontic treatment outcome study, which has concluded, and we are presently publishing or attempting to publish some of the clinical findings. The periodontal diagnosis and referral randomized clinical presentation study has been completed, as well as the analgesic use and effectiveness study. The data is being compiled and analyzed at this point in time. We have a few ongoing studies. The non-carious cervical lesion treatment outcomes random clinical trial study is closed for enrollment, but there is a 6-month follow-up, and the data is being collected at this point in time for the 6-month follow-ups. There is an implant outcomes study, which is a parallel study to the endodontic outcomes study, which is what I'm going to discuss today. The postoperative hypersensitivity random clinical trial is a follow-up study to the postoperative hypersensitivity in the Class 1 composite study. The partial or complete removal of deep caries is an evolution of the survey study that was done, and we also have a study on comparing caries classification systems. So today I get to go ahead and give you some of the primary findings from the outcomes in the primary endodontic therapy in a general practice setting. So in the private practice, we're often faced with the question of whether we should go ahead and do a root canal treatment, or if we should look at doing an extraction with some kind of restoration, either be it a fixed prosthetic restoration or an implant retained restoration. Most of the studies that have been done previous to our study were conducted in a specialist setting or in an academic setting. And they've also used dental insurance databases for the basis of their recommendations in the past. So being a practice-based research network, what we're looking at and what we were attempting to do was to go ahead and conduct a study in a private practice or in a practice-based situation for a private practitioner to have a better indication of what kind of treatment they would like to pursue. So our objectives of the study, again, were to determine the outcome of primary endodontic treatment in the general practice setting, and to see if there are certain factors associated with the success or failure of the endodontic treatment. So the way that the study was conducted is that we enrolled patients who presented for routine care and had primary endodontic treatment 3 to 5 years prior and were less than 70 years of age. The endodontic treatment could have been done by the general practitioner or by a specialist, but it needed to be restored by the general practitioner. So success and failure were determined in several different manners. If the tooth was missing, that quantified an automatic failure of the endodontic therapy. At that point in time, along with the preoperative radiograph and a present medical and dental history, the information was sent to the database and it was analyzed. Presence of the tooth did not automatically quantify a success. At that point in time, we did a clinical assessment which included periodontal probing as well as pain on percussion. With the radiograph, the medical and dental history, and a quality of life survey by the patient, along with the preoperative radiograph, all that information was sent to the database and then it was analyzed. Okay. So the breakdown as far as the enrollment of the patients go, there were actually more patients enrolled, but 11 patients were discounted for various reasons, and so they weren't included in the data. So there were 1,312 patients whose data was collected and analyzed, and the mean follow-up time was 3.9 years. The age median was 52 years with a range from 14 to 74 years, and 58% of those were female. There were 7% Hispanic, 4% who chose not to put down their ethnicity, and 89% who were non-Hispanic, non-Latino. And you can see that there was a high prevalence of white patients. 86% were white, 4% black, 5% Asian, and then less than 1% of Hawaiian Pacific Islander, Native Alaskan, and it should be Native American instead of, if you want to be politically correct, since I'm from Boulder. As far as the demographics of the patients go, there were 64 sites of practitioner investigators who went ahead and enrolled patients, and the average was 11 patients per site. The range of the practices or the practitioners were from 2 years of experience to 35 years of experience, with the median being 23 years. Most of the practices were suburban, 19% urban, 13% rural. And so what we found is that there is a high percentage of failure rate compared to previous studies. So what we found is a total of 19.1% of primary endodontic treated teeth with failure in a private practice setting. So 3.3% of those were associated with extraction, 2.2 with endodontic retreatment, 3.6 with pain on percussion, and 10.4 associated with periapical radiolucencies. Okay. The majority of the extractions were associated with root fractures. Some were associated with endodontic failures, a few with advanced periodontitis, recurrent decay, and one other. Okay. With the univariate analysis, we can conclude a couple of different things. What we found is that there is a much higher incidence of failure with initial diagnosis of pulpal necrosis compared to that of irreversible pulpitis. What we also found was that if there was the presence of a periapical lesion at the initial diagnosis, that had a higher incidence of failure than those without a periapical lesion. We can also find that multiple canal teeth have a much higher incidence of failure than that of single canal teeth, which is kind of to be expected, and that there wasn't a significant difference whether antibiotics were prescribed or not. From the walled confidence limits, what we also can see, or what they've also charted, is that the males had a higher incidence of failure than females, and that the Hispanics and Latinos had a higher incidence than non-Hispanics and non-Latino patients. Okay. So in conclusion, what we found is that the failure rate for primary endodontic treatment in the general practice is much higher than the other previous studies have suggested. And we found that it's probably associated with the more stringent criteria that we used. Most of the previous studies and the dental databases do not check for pain on percussion as well as periapical radiolucencies. So since they were incorporated into this study, we feel that those probably give us a better indication of true endodontic outcomes, as well as, unfortunately, it shows us that there's a higher failure rate of primary endodontic treatment. As far as the multivariate analysis goes, again, we found that presence of a periapical lesion at the initial diagnosis has a higher incidence of endodontic failure, as does a tooth with pulpal necrosis compared to irreversible pulpitis, teeth with multiple canals versus single canal teeth, the Hispanic Latino ethnicity, and male versus females. There were multiple components to this study. So what we are looking at in the future analysis of the conclusion of this study is to see if restoration outcomes also affect the primary endodontic treatment, if it contributes to failure or not, what kind of restorations, whether post placements or non-post placements, have an effect on the primary endodontic outcome treatment, as well as this is a little bit different, was that we also did a quality of life questionnaire to get a patient's perspective whether they felt the endodontic treatment was successful or not. That in conjunction with the implant treatment outcome study, we're hoping to go ahead and at that point in time give the practitioners a better basis for recommendation or for a course of treatment, whether the tooth should have endodontic treatment or whether the tooth should look at being extracted and restored with an implant. Okay. Any questions? Yes?
Was the question asked of the patient what time frame between root canal therapy and restoration placement?
Yes. Mm-hmm. Mm-hmm.
So why was the Hispanic and Latino
And I knew that was going to come up. And it's probably a downfall in our study, and we'll have to investigate it further. There were 91 Hispanic patients that were enrolled, and 37 of them came from one specific site, and they had a higher incidence of failure than probably the majority of the other practitioners. So that's probably not very accurate, but that's just from the clinical findings that we had. So they had approximately 1/3 of the enrolled Hispanic patients, but their incidence of failure rates were much higher. Yes?
Did the study look at endodontic therapy between specialists and general dentists?
Yes, and what we found is that the success rate and the failure rate was not that different between general dentists and specialists. And the reason is that the majority of endodontics done by the specialists happen to be the multi-canal teeth. So most general dentists tended to do the single canal teeth, whereas most of the specialists had probably the molar or more difficult teeth that had the endodontic treatment. So the success and failure rate between the specialist and the endodontist was about the same. Any other questions? Okay. So you can find out more about the findings from this study, as well as a synopsis of the ongoing studies and some of the previously completed studies at www.pronetwork.org. Thank you.